All right, today we're going to break down the big practice-changing updates from the 2025 Hungarian Oncology Guideline for HR-positive, HER2-negative breast cancer. We're going to focus on the key shifts in precision oncology that are really changing how we build our treatment algorithms. So here's the game plan. We'll kick things off with the new luminal paradigm, then we'll get into the strategies for both early and advanced disease. We'll also talk about exactly when to pull the trigger on chemotherapy, and then we'll wrap it all up with the key things you can take straight to your clinic. You know, this quote just nails it. It really gets to the heart of this 2025 update. We're officially done with the one-size-fits-all approach. The whole game now is about getting more granular, using a risk-stratified model, especially for this subtype, which is the one we see most often.
Okay, so what does this new paradigm actually look like in practice? Well, it's all about using surrogate markers, things we can test for easily, to really differentiate these luminal tumors. This lets us tailor how intense our treatment is right from day one.
And here's where the rubber meets the road. Look, we all want genomic testing, but let's be real. A lot of the time, we're relying on immunohistochemistry. So the key split is this. You have your Luminal A-like tumors on one side. Think low Ki-67, high progesterone receptor expression. These are generally your lower-risk patients. Then, on the other side, you've got Luminal B-like. That's where you see high Ki-67 or low PR, and that's a red flag. It tells you this is a higher-risk situation that's probably going to need more aggressive therapy.
So now, let's take that subtyping and apply it to adjuvant therapy in early-stage disease. This is honestly where this new way of thinking is going to have a huge impact on our day-to-day decisions. What's great is that the guideline gives us a super clear, step-by-step way to think about de-escalating chemo. First, you subtype. A lot of your Luminal A-like patients, they often won't need chemo. For those cases in the middle, the borderline ones, that's when a genomic assay like Oncotype DX becomes so important. And here is the magic number. For your node-negative patients, a recurrent score under 26 is a really strong signal that you can safely skip the chemotherapy. But here's the flip side. While we're de-escalating for some, we're actually stepping it up for others. We're now adding adjuvant CDK4/6 inhibitors for patients who have very specific high-risk features. The most obvious one? 4 or more positive axillary nodes. That's a no-brainer. But even if they have just 1 to 3 positive nodes, if you're also seeing a large tumor or high-grade disease, that's your cue to seriously consider adding agents like Abemaciclib or Ribociclib. All right, let's switch gears and talk about the metastatic setting. Here, the entire strategy does a 180. We're moving away from leading with chemotherapy and thinking much more about a smart sequence of targeted therapies, all driven by the tumor's specific molecular profile.
The philosophy here is crystal clear. In advanced disease, the main goal is to keep chemotherapy in our back pocket for as long as we possibly can. It's about extending survival, absolutely, but it's also about maintaining a high quality of life by using these smarter endocrine-based targeted therapies first.
For first-line therapy, there's no more debate. It is a CDK4/6 inhibitor plus endocrine therapy, period. This is the undisputed standard of care now, and that holds true even for patients with visceral metastases, as long as they are not in a true visceral crisis. It's also worth pointing out that the guideline specifically mentions the overall survival benefit that's been demonstrated with Ribociclib in this setting.
Now check this out. Around 40%, that is a huge number of our advanced HR-positive patients who have a PIK3CA mutation. When you have a target that's this common, you just can't afford not to look for it. This is exactly why routine genomic testing at the time of progression is no longer just a good idea, it's absolutely essential practice. This is basically your cheat sheet for second-line therapy and beyond. It's a beautiful thing, right? You find the mutation, you follow the map. You get a PIK3CA hit, you're looking at drugs like Alpelisib. The tumor develops an ESR1 mutation, boom, the oral SERD Elacestrant is your go-to. Patient has a germline BRCA mutation, time for a PARP inhibitor. This is precision medicine in action. We've said delay chemo over and over. So when do we finally pull that trigger? The guideline lays out 2 very specific rescue scenarios where chemotherapy is absolutely the right call. The first and most critical is a true visceral crisis. And let's be super clear about what this means, because the guideline is very explicit. This isn't just about seeing mets in the liver or lungs. This is when there's severe organ dysfunction. The organs are starting to fail, and you need a rapid response that only chemotherapy can deliver.
And the second reason is much more straightforward. You've run out of road. The disease is just plain hormone refractory. This means you've exhausted all the appropriate endocrine and targeted therapy options. The tumor has figured out a way around all of them, and chemotherapy just becomes the next logical step.
Okay, let's bring it all home. If you remember nothing else from this, these are the most critical, practice-changing takeaways from the new guideline. So, to boil it all down, in early breast cancer, use that luminal A versus B distinction and genomic scores to safely cut back on chemo, but escalate with adjuvant CDK4/6 inhibitors for your high-risk folks. In the metastatic setting, first line is a CDK4/6 inhibitor combo. That's non-negotiable. And finally, when a patient progresses, you must test. Test for PIK3CA, ESR1, gBRCA, because that's what guides your next move. This is the new standard of care. And this leaves us with the final, most important question. This isn't just about memorizing some academic update, it's a practical roadmap that changes how we practice. So the real question for all of us is, how are these new, more precise protocols going to directly change the journey for the very next patient who walks through your clinic door?